all to Medcast. On behalf of Taskmate, I would like to welcome you all to Medcast, Insights into Healthcare, a learning initiative by Taskmate. Today, it's a great pleasure to have with us Dr. Aniruddha Vyas, who is a consultant cardiologist in interventional cardiology, heart failure, and electrophysiology at Vishesh Jupiter Hospital, Indore. We welcome you, sir. Sir, we look forward to hear from you on today's topic of discussion, Mexiletine, an unexplored antiarrhythmic drug. Over to you, sir.
Thank you. Is my screen visible?
Yes, sir.
All right. And my voice is clear, right?
Yes, sir. Yes, sir.
So thanks a lot for this initiative. My responsibility in today's session is to discuss the role of Mexiletine. Mexiletine, as we all know, is a class 2 antiarrhythmic drug and is a vital utility in patients with ventricular tachycardia. Ventricular tachycardia storm or VT storm is a day-to-day clinical problem for treating physicians. It is important to understand the basic aspects of managing patients who have VT storm. VT storm is 3 or more sustained episodes of VT, VF, or appropriate shocks from AICD within 24 hours. There are clear laid guidelines and algorithms for management of patients with VT storm, but uh, it is difficult to understand and to follow them in practical real life scenario. The crux management is shock, DC shock. We need to understand what is the difference between synchronized and an unsynchronized DC shock. Synchronized shock, also called as cardioversion, is given whenever there is a well-formed QRS complexes during an arrhythmia, be it a broad complex VT. Unsynchronized shock is a shock when it is not synchronized to peak of R wave. It is given in the setting where there are no clear-cut R waves, for example, a situation like VF. It is very important to give and apply jelly over the shocking pedals while we give shock, otherwise it creates very dangerous burns over the skin. There are clear-cut guidelines to manage patients who have cardiac arrest. The time is vital. It is important to manage them with immediately starting with cardiopulmonary resuscitation involving chest massage followed by a shock. Delayed first response in such circumstances so is responsible for poor outcome for these patients. Now this is a EGM trace for a patient who has AICD in situ for a patient who developed VT, and we see the device delivers a 30 joule shock followed by a normal regular rhythm. When a patient comes with VT storms with an implantable ICD, the patient will present with multiple shocks from the device itself. It is very important to let rest the device. This is done by applying a magnet over the device. This suspends the therapy so that the patient uh, gets relief from getting multiple shocks from the device itself. Now, it is important to understand the history of the patient, why he has developed VT storm. Now, this was a 45-year-old gentleman who presented to us with episodes of VT storms and recurrent syncope. This was the monitor rhythm, and we can see the bidirectional VT which was going on. There was a history of ingestion of some Ayurvedic portion from a nearby uh, healer, and this was a component of that drug. Now you see, in such a portion which are available, it is very difficult to find out which of them is responsible for the pain relief and which one of them led to this VT storm. So there are always triggers for a VT storm. We need to identify the exact trigger. The various triggers for electrical storms are ischemia, electrolyte imbalance, worsening heart failure, and drug toxicity. Now, this was a lady actually, a 62-year-old lady, presenting with episodes of recurrent syncope. And we can see the dangerous, bizarre polymorphic VT. She was taking an offending drug, which was removed, and which was, uh, after taking detailed history, the drug was withheld from her treatment and she improved. The drug was digoxin. So, digoxin is a dangerous drug. It may lead to serious toxicities like this. This was another patient who presented with chest discomfort and perspiration to a nearby center, and the ECG was showing this broad QRS rhythm. Now, it is very important to identify the cause of this broad QRS rhythm. If we mislabel it as VT storm, we would continue to manage it on the lines of routine cardiac arrest and we would lose the patient. Now, this patient was having hyperkalemia. This ECG shows all the dangerous features of hyperkalemia. That is a broadening of QRS, shortening of ST segment. This is what is called as the sine wave pattern of hyperkalemia. See, by the time the patient reached us, was already in cardiac arrest. This time the patient was not breathing, was not responding. There was no pulse which was recordable. It is important to document and to understand the possibility of hyperkalemia at this point of time, because if we do not anticipate hyperkalemia at this point of time, we are going to lose the patient. The potassium was 10.3. It was treated with calcium gluconate, adrenaline, insulin, Lasix, and the ECG stabilized. This was another case of VT storm, which was because of QT prolongation secondary to IV amiodarone, which was given for PSVT. This is another example of VT storm, you can see, which is because of congenital long QT syndrome. So, how do we measure QT interval? QT interval is measured beginning of Q wave to the end of T wave. That is the total QTU interval. And if this QT interval is more than half of RR interval, this is called as prolonged QT. This prolonged QT interval is responsible for dangerous ventricular arrhythmia, including fibrillation. There is another setting where patients may present with such polymorphic ventricular tachycardia. This is the setting is just like this. So it is important that we see during sinus rhythm what is the cause. So we can see there is ST elevation in lead 1, followed by a run of polymorphic VT. So this is ischemic polymorphic VT. After giving DC shock, we can see the rhythm. It shows extensive ventricular epi. This polymorphic VT is distinct from torsade, which is seen with long QT. It is associated with normal QT interval. It is associated with a early coupled PVCs, and the treatment is lidocaine and revascularization. While the VT, which is associated with long QT interval, it is called as torsade, and it is associated with late coupled PVCs, a prolonged QT interval, and the initial treatment is pacing, isoproterenol, and magnesium. There's another rather innocuous, mild, benign ventricular rhythm, which is seen with ventricular tachycardia. It is accelerated idioventricular rhythm. It is seen in a partly occluding vessel or after successful thrombolysis. Such kind of rhythm is because of acceleration of ectopic focus in the ventricle. Such kind of rhythm does not need treatment with DC shock. If it is causing hemodynamic instability, one can treat with atropine to increase the sinus rate and overdrive the ventricular rhythm. Another common VT which is seen with MI is the scar VT, which is because of old infarct in the myocardium. This is the most common ventricular arrhythmia we see in our clinical practice. The scar can be because of ischemia, or it can be because of healed myocarditic feature. VT can also be seen in setting of complete heart block, like this. Okay, see this gentleman having complete heart block and having PVCs, and because of the prolongation of QT interval, this leads to episodes of dorsal. So basically, it is important to have a correct diagnosis, to identify and treat the trigger, to treat with antiarrhythmic medicines, to use sedation and general anesthesia, to decrease the sympathetic drive by using drugs and nerve blocks, and to do pacing. This is the management for patient who present with VT storm. This is the emergency treatment. Now, this is the maintenance treatment for any patient who had episode of VT. Here comes the role of maintenance medicines, role of AICD, public education, and CPR trainings. As far as maintenance medicines are concerned, there are many, out of which we all know from the Vaughan-Williams classification, as they are classified into class 1, 2, 3, and 4 category of medicine. Now class 2 are the beta blockers, class 1A, class 1B, and class 1C. They are the sodium channel blockers. Class 1B medicine is Mexiletine. It is a drug which is of interest in this discussion. Now ACC, AHA, and HRS guidelines, they have given indication to treatment with Mexiletine in patients who have ventricular tachycardia or ventricular fibrillation. As I told, it is class 1B antiarrhythmic agent. It's a sodium channel blocker. It acts on phase 0 of action potential. And it is structurally similar to lidocaine, but it is orally active. It acts on the sodium channels. The site of action is the Purkinje fibers. Electrophysiologically, it is oral congener of lidocaine. It acts for patients who have normal conduction system. It has minimal effect on the cardiac impulse generation and propagation. It does not lead to any second degree or third degree heart blocks. It does not lead to QT prolongation. It does not depresses the sinus rate. It does not prolong the sinus node recovery time. It has no effect on conduction velocity in ERPs of drug. So basically, it has no effect on sinus node. It does not affect the AVA and ERP. Does not affect the PR interval. Does not affect QRS duration and QT interval. So electrophysiologically, Mexiletine is a very safe drug. It does not have much proarrhythmic side effects. It does not have proarrhythmic side effects, uh, either bradycardic or tachycardic. It also does not have any significant effect on hemodynamics. Like IV imidron leads to hypotension. Beta blockers lead to hypotension, while Mexiletine is a safe drug. It does not lead to hypotension. Mexiletine is well absorbed from the GI tract. The peak blood levels are reached in 2 to 3 hours. It has the first pass metabolism is low, and 10% of it is excreted in urine. So it is individualized, the dose is individualized on the basis of response and tolerance, both of which are dose related. Administration with food or antacid is recommended. The dosage initiation is 200 milligram every 8 hours, and when the drug effect has come, 2 to 3 days are required for dose adjustment. When rapid control of tachyarrhythmia is essential, the loading dose is 400 milligram, followed by 200 milligram thrice daily. While a 200 milligram thrice daily dose can be restarted when rapid control is not essential. It is contraindicated in patients with cardiogenic shock, with pre-existing second degree AV block or third degree AV block. It is generally well tolerated. It has reversible GI and nervous system side effects. So it is indicated in patients with sustained VT. It has a drug which has a moderate efficacy. It is an agent with appropriate, appreciable safety. It is safe in patients who have LV dysfunction. It is safe in patients with QT prolongation. The effect is reversible and does not have any lethal adverse effect. It has a class 1B recommendation for management with VT and is a very good adjunct and add-on drug for patients with for amidron, sotalol, beta blockers, or patients on ICT. Thank you. If there are any questions, we can discuss.
If any participant is having any question, you can please write in the chat box. Okay, so we will be waiting for 2 to 3 minutes more. If there will be any question, you can just ask. Otherwise, we can conclude with the session.
I think we can call off because all the participants have my number. If they would want to discuss, we will discuss personally. All right?
Okay, sure, sir. So thank you so much, doctor, for joining with us today. It was really an insightful discussion for us as well as our listeners. So thank you so much, doctor. Thank you and have a good day, sir.